every woman's breasts are different. Having dense breasts is normal. It just means your breasts have more fibrous and glandular tissue than fat. When a woman's breasts are found to be more than 50% dense, mammograms alone may not be adequate for screening. Breast density is identified through a review of your mammogram. For women with dense breasts, both dense tissue and cancer appear white on a mammogram, which can camouflage cancers. However, ultrasound displays cancer as black against the white tissue, helping doctors find hidden cancers. If you are informed you have dense breasts, your physician may suggest another screening exam with 3D automated breast ultrasound. The Invenia ABUS 2.0 automated breast ultrasound system comfortably and quickly images dense breasts. Studies have shown Invenia ABUS 2.0 increases the ability to detect cancer when performed after a mammogram. This video demonstrates what you can expect if you have an Invenia ABUS 2.0 breast exam. You will be asked to lie on your back and be placed in position for the exam. Ultrasound lotion or gel will be applied to your breasts. A mesh membrane will cover the scanner. A new membrane is used with each patient. The operator will place the scanner on your breast and apply gentle pressure to help ensure that there is contact with your skin on all sides. Once the scanner is in place, the operator will start the scan. It will take under 1 minute to move across your breast. This may be done 3 times on each breast to create a full exam. Additional views may be taken if needed. The full exam is typically 15 to 20 minutes. After your exam, the operator will send your images to a radiologist to be evaluated, and you will be contacted with your results. Invenia ABUS 2.0, helping physicians look differently at dense breast tissue.
Dear colleagues, I'm happy to present to you a short lecture on 3D ABUS and the impact of this new technology for women with dense breasts. These are my disclosures, and it has been widely acknowledged that mammography is not beneficial in women with dense breasts. Women that have C and D breast composition have major limitation in the detection of cancers that are presented without calcifications. And the added value of supplemental screening has been shown in this very recent study following combined digital mammography as well as DBD as tomosynthesis. And in order to overpass the limitations of handheld breast ultrasound, ABUS has been developed. And the acquisition is performed starting the scan from the inferior part towards the uppermost part of the breast with the use of a large transducer that is 3 times larger than the transducer that is used with handheld breast ultrasound. Once the ABUS acquisition is obtained, we have the ability to reconstruct into multiplanar 3D images. These are the transverse, the X plane, this is the raw images, and this is the coronal, the reconstructed image, and the sagittal plane. We have the ability to review the breast in 3-dimensional breast anatomy, starting superficially from the skin, the subcutaneous fat, the fibroglandular tissue, and breast lobules. For each breast, 3 volumes are obtained, and these are the AP, the lateral, and also the medial. And though these 3 volumes overlap to each other to cover the denser part of the breast. There are several prospective studies that have been shown the increment of breast cancer detection when supplemental screening with ABUS in addition to mammography was conducted, and 2.5 cancers were additional cancers detected when ABUS was combined to mammography, and most importantly, most of these cancers were invasive cancers, node negative. And this is a quite busy table, but it shows that ABUS has equivalent performance in cancer detection rate compared to handheld breast ultrasound. However, in addition, ABUS has several advantages. It is operator-independent technique. It produces high reproducibility of images. We provide large field of view, multiplanar and tomographic thin slices. The coronal plane provides new information, and this is the retraction phenomenon sign, which has high specificity and sensitivity for invasive cancers. Batch reading, double reading, and volumetric review of data is not feasible, as well as the integration of CAD systems. The interpretation time varies between different studies from 3 to 9 minutes, and we started the implementation of ABUS in our practice in the beginning of 2016. We perform about 25 to 30 ABUS examinations per day. 70% are screening, 30% of our volume is diagnostic. ABUS is the initial examination in women with known dense breast composition, and we perform handheld. We use handheld as a second look breast ultrasound. This is a screening ABUS in the 46-year-old, where we detected on the coronal, the transverse, and sagittal plane a suspicious mass with indistinct margins, also shown on the transverse slices, thin slices. But in addition to the first mass, there is a second suspicious abnormality situated superiorly and laterally to the first one, also seen on all three planes. Both of these lesions were further assessed with handheld breast ultrasound, and this proved to be an invasive lobular cancer grade 2. And looking back in mammography of this patient, this is the left breast, even in retrospect, both of the masses were not identified, neither they were seen on DBD slices. In order to have a successful implementation of ABUS, it is important to have close collaboration between our patient technologists and to have close feedback between radiologists and technologists. Our patients must be informed before starting the examination to avoid speaking and coughing during the acquisitions and also to breathe normally. It is important in order to optimize ABUS image quality that our technologist provides appropriate positioning, applies meticulous use of lotion, has complete coverage of all dense breast tissue, that the adjustment of depth is correct, also that the application of compression is adequate, and also the proper transducer placement. Now, from radiologist's point of view, it is important to have clinical information in every patient before starting interpreting ABUS studies, to read all volumes and all planes, and also to start working, at least in the beginning, in hybrid environment, to perform both handheld and ABUS. It is important to be able to identify these post-surgical changes from real lesions, like this abnormality, which presented an invasive lobular carcinoma. So combined reading also is another important point that has shown to improve radiologist performance. Radiologists must be able to understand artifacts that are created sometimes on the images and how they appear in order to be able to distinguish them from real abnormalities. In this article that was published back in 2019 in Radiographics by Ingolf Karst, there is a table where you can read further the type of artifacts. They are subcategorized into different categories, their causes, and also their appearance. Also, continuous education is important for both radiologists and technologists in order to enhance the quality of ABUS studies. The integration of CAD system has shown to improve confidence and also accuracy, and CAD, which is called QView CAD, it uses deep learning and machine learning and has the ability to automatically extract features from suspicious lesions and areas that are larger than 5 millimeters and to generate a score of suspiciousness. This is the navigator image. This is called minimum intensity projection. You can see within the circle the suspicious abnormality that has been automatically pointed out by the algorithm. A large study that was published in Radiology and evaluated more than 1,500 ABUS images, further evaluated the performance and the reading time of ABUS with or without a CAD system, and the results of this study that showed that CAD upgraded malignancies for beginning readers and also for experienced readers. CAT allowed for benign lesions to be downgraded from biopsy to follow-up recommendation. Also, for both beginners and advanced readers, the reading time was decreased by 30% with the addition of CAT system to ABUS study. And this is an ABUS screening in a patient. In a screening patient where in the right breast there is a suspicious mass seen on all three projections, and you can see that the mass was highlighted by CAT. This was an invasive ductal carcinoma. So the take-home messages is the mammography is not effective enough in women with dense breast, that ABUS is efficient and reproducible, and that it addresses the operator dependence that have been encountered with handheld breast ultrasound, that ABUS has equivalent performance in cancer detection rate compared to handheld and can be used as supplemental screening tool in women with dense breast, and that the integration of CAT reduces ABUS reading time and it improves performance of breast cancer detection. And with this, I would like to thank you all for your attention. Thank you.